Hospitals and Apollo Cradle, past Chairman Adolescent Committee AOGD, past Vice President DGF North, Co-Chairman Medical Legal Cell DGF. I welcome Dr. Shakuntala Kumar.
Dr. Deepti Nav, Dr. Jyoti for giving me this opportunity. Dr. Sharda Jain ma'am, you have given me a platform where I can really share my case and tell actually what happened. Because Dr. Neha and Dr. Chitra Setia have covered the whole of the theoretical part. And here I will briefly be telling you the do's and don'ts in VBAC, wherein what, how, and when we should be doing. Dr. Neha has beautifully, shown in this slide as to what is the time when we have to, discuss the onset of VBAC. Whether the patient will be delivering by vaginal birthing after cesarean section. So the exact timing she has very beautifully highlighted. So this was a very important slide. I just, for the sake of repetition, I'm showing this slide once again. And whether we have to do a VBAC or whether we have to go for a repeat cesarean section is the time that you have to highlight and talk with the patient. So when we have a plan, we have to counsel the patient in detail as to what are the points that are to be discussed, beautifully highlighted by Dr. Chitra, and what are the special considerations. If there are any complicating obstetric factors, they are to be discussed with the patient. And there are some factors probably with which you can discuss with the patient. There are some absolute contraindications where you have to just put your decision and put your foot down and talk about repeat cesarean section. And the risk factors, again, very beautifully highlighted, the risk factors to the mother and to the fetus, whether the mother is at risk of a rupture or a dehiscence. Dehiscence mostly is discovered intraoperatively. Sometimes if you are really vigilant, you might suspect it. The major and the minor factors where VBAC would be successful, on the left are the major factors. On the right, these are the minor factors. The induced labor in the past, the no previous vaginal birthing, BMI of more than 30, a previous C-section for shoulder dystocia done in the past are the major factors, and the minor factors are delineated mainly if the woman had a previous preterm C-section or her cervical dilatation at admission was less than 4 centimeters, then probably she may land up with an unsuccessful VBAC. These are the points where you have to look at the selection of patient. How do you select? And select very, very carefully. Intrapartum, you have to give a trial. You have to, either you are inducing or augmenting, you have to wait for a stipulated period of time, beyond which, if your partogram is going haywire, you think that there has been a delay, keep on documenting it. As Dr. Chitra said, at every step, keep on documenting, keep on informing, and if still you're not obtaining the consent, talk to the attendants and document the refusal of consent. Well, you have to observe for all these signs if the patient has had a loss of station of the presenting part, if there has been cessation of previously efficient uterine activity, if there has been maternal tachycardia, hypotension or shock, has there been an abnormal CTG, chest pain or shoulder tip pain, or if she had any acute onset of tenderness, then a patient may be going for a dehiscence or may be having a frank rupture. Well, this is a slide which is telling us what is the difference between a scar dehiscence and a scar rupture. So, when a patient has had a scar dehiscence, then probably there will not be any bleeding in the peritoneal cavity. The fetus is not extruded out of the peritoneal cavity. But in case of uterine rupture, there are different signs and symptoms. Not wasting much of the time, I'll just come to my case, what happened in my case, for which I was given such a, I became a page 3 celebrity overnight. This was a case, I'll just tell you what happened in my case. If the House has the permission, can I discuss my case?
Yes, Dr. Shakuntala, please do. This is what we want. Yes.
Yes.
Wish for. So, please do. Please.
Yes, ma'am. So this was one patient who came to our hospital on 24th of July 17th for her third pregnancy, with her LMP was documented as 25th of May 2017. In the past, she had had a full-term intrauterine death, which was delivered by cesarean section somewhere else in April 2011. I do not have the details of this pregnancy and what happened, why did she land up in IUD, and why was she delivered by LSCS. Thereafter, she had a pregnancy which was duly taken care of by me, and she had a full-term VBAC under my care in the month of July 2012. And in the present pregnancy, which is in case here, it was her third pregnancy, for which she first visited to me on 24th of July 2017. We kept on following her up. Incidentally, this was a CGHS patient. Just wanted to tell you, just for the sake of completion of my records. And she was found to be, during my examination, she was found to be anemic and hypothyroid. We started all the relevant treatments, and routine ultrasounds and checkups were done. In her last ultrasound, that was done in the month of January 2018, it was done in my setup only. She was found to be 35 weeks plus 5 days maturity, with her estimated fetal weight of 2.9 kgs. She reported again to me on 11th of February 2018, and she was in labor. I took in my hospital, actually we are a NABH hospital, and at every step we have to follow a lot of, clerical work is done, and a lot of consent taking, and all the documentation is supposed to be really diligent. Everybody is after your life if you have not finished any paper or left anything unsigned, or if your consent and other forms are not proper. So consent for TOLEC was duly taken after informing everything to the patient's attendant. This patient comes to me from Narela, all the way from Narela to this hospital, which is located near Delhi University. And for the sake, because he had a very good past pregnancy experience, he had a vaginal birthing, was satisfied with me. This patient was admitted, and her labor was augmented after observing her for some time with 0.5 unit oxytocin. As Dr. Chitra Sethia said, I also do not use misoprostol or prostaglandin in any of the cases. And I, if at all, use oxytocin in previous cesarean, use in minimum dosages. So this was on 10th of, this was on 11th of February 2018. We noted no progress. So what we did was we asked her to rest after 10 p.m. After 10 p.m. at night, we just told her to stop the oxytocin drip, and I continued with a plain ringer lactate drip, and gave orders to restart oxytocin at around 4 o'clock in the morning with 0.5 unit once again. At around 6 a.m., I increased the dosage to 1 unit. And then patient was shifted to labor room when I was given a call that the patient is in active labor. I shifted the patient to labor room at 9 a.m. And thereafter, throughout, I was with the patient. Now, inside the labor room, under my constant supervision, the patient was taken care of. I was monitoring. I was the one who was, constantly supervising the delivery. And anticipating vaginal delivery, when patient was almost 8-9 centimeter dilated, I sent a call for the pediatrician, who was also standing with me, anticipating a vaginal delivery. After some time, I noticed that there has been no descent of the presenting part, despite of full dilatation for a while. It was almost 10-15 minutes. There was full dilatation, but no descent of the presenting part. I informed this duly to the husband of the patient, who was waiting outside, and the mother-in-law. Took a written consent and took up the patient right there and then and there for C-section. Intraoperatively, what happened was that I just noted a rent which was there in the uterine scar and in the adjacent bladder wall. This was informed to the patient's husband standing outside. What happens in my hospital, if there is a protocol that if a vaginal birthing is converted into a C-section, then there is a team of doctor and some adjacent help comes, so that they keep on informing the patient's attendant outside. If anything I have to inform, I go, I show my face, tell them what is going on, and come back. So a call, incidentally, that was a day when my surgeon's call day was also there, and he was also present in house. So a call was sent to the surgeon and the urologist for the cesarean section. When the call was sent to the anesthetist, incidentally, that's my husband. He was also there in house. He was also called immediately, who like kind of came immediately, noted everything, all the vitals, and the CTG monitor was on. So he, reflexly he noted the fetal heart sound also, the fetal heart rate, and mentioned in his anesthesia records. So since I looked, but the moment I looked at the rent, there is a nearby gynecologist who practices very nearby. So I called her also, just in case that I might need her. Now, in the intraoperative times, this rent hoop which was seen, it was not bleeding. There was no blood seen in the peritoneal cavity. Patient was throughout hemodynamically stable. There was no sign of dehydration, and actually I had taken a consent for hysterectomy, anticipating worst, but it was not required. I just did the rent repair, and considering this as a scar dehiscence, I did bilateral tubal ligation, did the rent repair, catheterized. The patient was already catheterized. There was no other problem. Bladder was absolutely taken care of by the urologist, and the patient left the OT absolutely uneventfully. Total number of blood transfusions that were done for the sake of anticipating blood loss, we had asked for blood, so we transfused 2 units of whole blood to the patient. And the post-operative recovery was very, very uneventful. Since again, I will say that we are an NABH hospital, so we have a protocol that every day we take a patient satisfaction record, and we take a consent, a written, a signature of the patient's attendance or the patient that they are satisfied with the treatment. So every day that signature was taken on the satisfaction records. Now, what are the medical legal issues that, hounded me? What happened was, this patient, since at that time I did not have a NICU in my place, the pediatrician was called. She called the senior pediatrician as well. So there were 2 pediatricians who are managing the baby. They promptly handled the baby, and the APGARs that was noted at birth was 2, 5, and 7. So after that, the baby was immediately transferred to the nearby NICU where my senior pediatrician goes. This very same day, this baby was transferred from that NICU without anybody's knowledge to another NICU. And in between, the baby was transferred twice again to various NICUs, about which I am not very much well aware of. And this baby had HIE, moderate type. Now, how was I sued? Was that, what happened was that this patient said that I was given a wrong, I was given, I induced the patient. The first litigation point that the patient, I'll just stop sharing the slide so that we start discussing. Please excuse me. So the first thing that happened was that this patient, he told me that you have induced the patient on the wrong dates. Calculating the dates wrongly, you have prematurely induced the patient. That was the first point that this patient put up the objection to. The second point, this patient said that the whole night my wife was in pain. His words were कि मेरी वाइफ चिल्लाती रही पूरी रात, बहुत बुरी तरह से रोती रही. There were sheets of liquid lacquer which were like staining the sheets. तो ये लोग sheets पे sheets change करते रहे, but doctor ना तो उनको आना था ना वो आई. Doctor बिल्कुल आई ही नहीं. Just for your information, my hospital and my residential place are the same. I am in house all the times. So he blamed me that the whole night the sheets kept being changed and the doctor was not informed. और मेरी वाइफ दर्द से चिल्लाती रही और पेशेंट का यूट्रस रप्चर रात में ही हो गया. In the morning when she went, she took the baby she took the patient to the OT, and then she came out and she said कि these are the words, exactly the words that the patient used, कि बच्चा उसका सिर बाहर आ रहा है और डॉक्टर शकुंतला pushed the baby inside. मैंने बच्चे को वापस धक्का मारा, and then I, for the sake of converting this vaginal birthing into a C-section, मैंने जो बच्चा बाहर आ रहा था उसको वापस अंदर डाला और मैंने बाहर आके बोला सिजेरियन करना पड़ेगा, एंड उसके बाद मैंने सिजेरियन किया. These are the points on which I was sued by this patient, and his points were so repetitive and so vehement that he went to the Women Forum, he went to the DMC, he went to the Delhi Nursing Home Forum, and I don't know how many, the police station, the nearby police station he went to. Everywhere I was asked to present my files. I was asked to give my records, and in Delhi Medical Council, I was, I don't know what happened, but misquoted as I induced the patient. The Delhi Medical Council noted that I have induced the patient. But friends, why I was saved from this misconception or confusion was one thing, that the notes were immaculate. The notes were everywhere, number one. The consent was there at every step. The patient also alleged that मैं आके पेशेंट को एक्सप्लेन करती रही ओटी के बाहर, एंड आई डिड नॉट केयर. मेरी वाइफ अंदर चिल्लाती रही, एंड आई डिड नॉट केयर टू टेक केयर ऑफ द पेशेंट. मैं तो सिर्फ बाहर आके पेशेंट से गप्पे मारती रही अटेंडेंट से, एंड आई स्टार्टेड एक्सप्लेनिंग. सो व्हाट सेव्ड मी वाज, number one, my consent. Number two, my immaculate explanation on the consent, which was done by my own handwriting, कि ये problems आपको हो सकती हैं. Daily satisfaction record was there. Every day, on the day when he alleged कि खूब सारी शीट्स गीली हो गई थी और मेरी वाइफ दर्द से चिल्ला रही थी, उस दिन पेशेंट ने खुद कंसेंट पे साइन किया कि मैं सेटिस्फाइड हूँ ट्रीटमेंट से. और उसके अगले दिन और उन सब सब्सिक्वेंट डेज जितने दिन पेशेंट यहाँ रहा है, I had this consent signed by the, either by the patient or by the husband of the patient. Lastly, my records were like everywhere, everything was recorded. And patient had an uneventful recovery. Massive transfusion was not required, and patient went home uneventfully. After 9 months of stay in one or the other NICUs, patient came back, took some data from my staff, forged two of the documents were forged by the patient. He forged two of the documents, which were like quoted in DMC, that Dr. Shakuntala, you gave standing instruction for admission, which was a forged document. The patient had forged the document. That is what that saved me in MCI. In the Medical Council of India, they noted all the forged documents. They noted all the records, the consents, and the satisfaction record. And then they also had asked few questions from the pediatricians, whether they were present or they were not present at the time of delivery. And I think that is what that has taken care of me. And of course, the extensive, post-mortem of the whole case file, whether I induced the patient or not, whether patient came in spontaneous labor. So these were the things that saved me. So I just wanted to highlight my case to this August forum. And I am so extremely thankful to the forum and to Madam Sharda Jain that I got this platform to at least speak my heart out. But I want to emphasize only one thing, that patient can get annoyed on anything, number one. And number two, you will be screwed if your records are not complete and immaculate. That is something, and definitely सुनवाई है अगर हमारा रिकॉर्ड कंप्लीट है. तो अगर हमने कंसेंट को डॉक्यूमेंट किया है और डॉक्यूमेंट को मेंशन किया है कि द डॉक्यूमेंटेशन हैज बीन डन प्रॉपर्ली, देन आई थिंक वी विल बी हर्ड. द लॉ इज नॉट एब्सोल्युटली ब्लाइंड. आई थैंक यू फॉर योर पेशेंट लिसनिंग. आई एम ओपन टू ऑल द क्वेश्चंस.
I think I will just make one comment about Dr. Shakuntala's presentation. Dr. Shakuntala was heard in Delhi Medical Council. Nothing was found wrong with her except this induction issue. And it was very clearly her documentation had been there at the time of initially the patient has come in labor. She has written down 4 hours she was in labor, and then she said the pains are mild. She had done a CTG and everything was okay. She was not progressing well. She did augment, but since the time she had augmented her, she was throughout with the patient, and the records were absolutely immaculate. And because technically at the time of cesarean, when she found the scar dehiscence, the baby was taken up, they have documented that the baby was asphyxiated. Baby can be asphyxiated otherwise also. But in this particular case, the scar adhesions were there, asphyxiated, it was there. Now, the only thing, the problem occurred in her case was that the pediatrician was known to big people in Delhi Medical Council. She said, I was not there. She just said, I was not there. But it is the documentation of the other staff that, they call the pediatrician well in advance at 8 centimeter dilatation. She was expecting a vaginal delivery. So the other people said, that the pediatrician had been there. Anyway, but what saved her in MCI was her documentation and her consent for TOLAC. When initially she had come, that time also she has said that, look, you have had one vaginal delivery, does not mean that you will sail through second time. Again, at the time when she had come in labor, she had again said that you have given a consent, but I'm again repeating this TOLAC. Are you ready for this particular thing? So I think, her explanation twice saved her. See, whenever people get into litigation, वो तो पूरा चक्कर तो लगाना ही पड़ेगा. All that kind of things are going to be there. But what I feel, I again come back to Dr. Chitra Setia's this thing, that I think my interaction with her many years back, she said, Madam, this consent is very important. Every gynecologist who want to give a vaginal delivery after cesarean section, she must hand it over 3 weeks in advance, this particular consent to them, and it must be told to them properly कि मुझे जो भी consent में लिखा गया है वो सब मुझको पता है, मुझको सब समझ आ रहा है, सब कुछ करना है, ये उसको देना बहुत जरूरी है. If it is not done, then I think you are not saved. Repeat cesarean will occur, rupture is going to occur, चाहे किताबों में कितना ही 0.5% लिखा होगा, पर मान के चलिए 2 to 3% तो rupture है ही. And the baby can die, baby can have a neurological deficit. Shakuntala's baby is neurologically deficit baby है, and that is why they want कि Madam Rich है, इनसे extract करते. So what I'm trying to say, what will save, I think, people are here to give consent. I will ask again Chitra to speak, give her mind, and again I ask Shakuntala, and people can share their own thing. I can tell you 20% of litigations are against gynecologists for giving chance for vaginal delivery after cesarean section. 70% will sail through. But I think your documentations have to be great. You are not saved.
True, very true, ma'am.
Very true.
Documentation.
I want to tell you that, Dr. Very senior professor got stuck with Dr. Shakuntala, in spite of her notes were there that, patient has come in labor. She's in labor for 4 hours. And she had written that cervical dilation is 1.5 centimeter. Then also she had written in DMC notes that she was induced. It means, you have not done a thorough homework. So what I'm trying to say that your documentation only saves you.
Actually, madam, it is not. What I want to tell you is that this person is so extremely influential. He has been. There are people who will be touching your feet. They will be telling you.
We are not going to. We are going to only talk scientific. We are going to talk scientific. I will ask Chitra's comment, and I will ask your comment. I will ask other people's comment.
Sure, ma'am. Sure.
No, I think the right thing was this. And in any case of VBAC, it is worthwhile writing notes if they're in active labor every 15 minutes. In fact, we have made charts also in Apollo. We have made charts that every, in active labor, in first stage of labor, every half an hour, there is a time mentioned, the contractions are mentioned, and the fetal heart is mentioned. And once they are in active labor, then they are mentioned every 15 minutes. There is a record. There is a tabular form of the record of the fetal heart mentioned. So that works out very well. The sisters also know how to rule it, how to document it, because sometimes, even the resident, everyone is in the OT and a patient is in labor, maybe in active labor. Our sisters are very well trained, but nobody looks at their notes. So we made this table that they have to enter the fetal heart record. And if the resident is there, the moment they're in active labor, we tell our residents to get out of the OT and go back to the labor room. You know, sometimes there are instances when even if we have two residents, they are busy somewhere or the other. And there are instances when all of us have faced that it's only the sister in the labor room. So that has to be documented. And even the sisters can mention the fetal heart. And the moment they're in active labor, they call the residents, whoever they're assisting, they wash out and go to the labor room. And
Dr. Chitra, you mentioned one particular thing is that, you know, scanning of your records is very important. The doctors first before scanning, they should start scanning their sheets, and, you know, the copy should be there, because the patient will find convenient only to give the records which are in their favor and, you know, keep back the records which are not in your favor. So I think the scanning of the records is very, very important.
I think all of us go into computerized OPDs. I mean, we have gone into it for the past 3 years. But in the OPD, if suppose this thing is not facilitated, if you don't have a computer, scan them. Scan the notes and put it there, so that you can go back and take out those records. It's very, very important. Because, you know, even things like this, a patient can sue you with a photocopy of the front page of your prescription. The backside, they will not, this thing, if you've written the details on the backside of your prescription, I mean, after all, OPD records, we write on both sides of the paper. And if the backside is not claimed, we have had cases filed where they have mentioned the front part of the prescription and showed it. It's lucky that we had the back part also scanned, so we knew what was written over there. So there are even things like this happen. So those who are not maintaining their OPD records, please mention it. Because especially in cases of VBAC, when you're counseling for TOLAC, this should be mentioned in your OPD notes that you have.
We would like people to share their experience. I can see Ritu Khanna from Allahabad also has joined. In case she wants to make any comment, anybody senior want to make any comments, please, your experience, it will be more than welcome.
Ma'am, I want to share one thing, that whenever there is previous vaginal delivery after cesarean section, then we become little liberal in giving a trial of labor. And because I also had lost the baby in such situation, when the patient had first cesarean section and second vaginal delivery, and then she came to me. She was already in labor, 4 centimeters dilated. I was in the hospital. Patient was going through labor, and suddenly there was a fetal distress. When I shifted her, and till the time we delivered the baby after giving spinal and all, so that was the problem there. Then I thought that we should have gone for GA that time instead of going for spinal.
Yeah.
By the time I opened this, baby was dead and there was a scar disease. So though the patient did not do a litigation, but still I feel very sorry for it, because I lost that baby. So previous cesarean section, even after one vaginal birth, one should be really careful. We should not think that because she had already a vaginal delivery, the baby, because maybe scar was not that good enough, or as madam told that you don't explore the lower segment after delivery, and then there may be some rent which really opened up next time. So these things are important for the benefit of the patient and yourself.
Madam, can I say something?
Yeah.
Yes.
There are two things which I have learned from this case, and that is that a documentation of discussion with the patient at around 36-37 weeks, that we didn't used to document in our files. Now I have started doing that as well, that we document the discussion that we've had with the patient at around 36-37 weeks, that they have an earnest desire for vaginal birthing after C-section. That is documented, consent is taken, and now that we have started documenting in our file, number one. Number two, what happens that CTG becomes, the color fades after a while. So what Dr. Chitra said is very pertinent, that we should scan our files. We should scan our files. And also what we've started doing is we've started taking a scanning of those CTG records that we do on time to time. There is one problem, and that is when we are doing continuous CTG monitoring, all the times we are not taking records. That is something, that is one lacuna, because we cannot do multiple recordings. Now we've been very careful. We do it whenever we feel that there is some patient may tell you that probably there was a dip which we did not record, but continuous CTG monitoring is being done, though we do not record it all the times, but maybe multiple records are there which we should always scan and maintain the record of those CTG records.
We have Kishore Rajurkar. You want to make any comments, sir?
I just want to make one comment that because I'm working in a government hospital, and there we also do conduct the VBACs. But I really, what the recommendations are there that all the patients in labor who have to go under VBAC, they have to really, we have to really monitor them, and it is not possible most of the time in the government hospitals. So therefore, although they say that we should do in a tertiary hospital, in a big hospital, practically it is not possible. And here I want to say about the recommendations are there that you have to have a resident, anesthetist should be there all the time. So that is possible only in a big hospital. So therefore, I should not recommend VBAC in any nursing home in which the anesthetist is not there. Because the anesthetist will take time to come. So therefore, whenever you see the RCOG guidance or wherever, VBAC is done only in places where everything is possible within a short time. So that's all I find that, and I find that although the residents are present in government hospitals, but because of the load of the patients, we are just hum to bach jate hain because they are not suing us. Otherwise, typically we have more structured cases, but luckily they don't sue us. That's all. That's what I want to say.
Dr. Kishore, I feel, tertiary care, to make it mandatory for tertiary care hospital, I will not agree. But anywhere the cesarean facilities are available and the team is competent to do cesarean hysterectomy.
Competently, but they should be available. Availability is the thing, madam. Availability has to be there because sometimes they are not available at right time. 15-20 minutes, you have 30 minutes. We should get it done. Sometimes they don't come.
Shashi, you have to speak something, Leena.
Nee, that is what
one by one. Yes, Chitra.
Nee, that's what I had mentioned earlier. That tertiary hospital is not mandatory, but an anesthetist should be there round the clock because that time taken is very important, especially in a rupture case, to save the baby. So that is one mandatory thing, that whatever hospital you're doing it, an anesthetist should be there round the clock and a pediatrician should be there round the clock. And, within 5 minutes, they should be there, available.
May I add something, Dr. Chitra?
Yeah.
I was just listening to this and I think it's a very, very important topic. One point which Dr. Shakuntala mentioned about, keeping, the CTG records. We've also started keeping, and what we are doing is for the second stage labor, we are keeping records, parts of that, especially when you've had a fetal distress, you've taken up a patient for a section, emergency section. So we've been keeping those records because, as we all know, electronic records, they just get wiped out. So if we expect these records to be there with our MRD after 2 or 3 months, we'll find that we will not get it traced. That's number one, very important, because CTG records are really very, very important. No doubt about it. The second thing I remember, one of the doctors, I'm just forgetting who mentioned just now. She mentioned about a case, yes, Dr. Ela mentioned, where the patient, of course, did not sue her, but she mentioned that the anesthetist gave spinal anesthesia. Now, most of the time, though we have in-house, in a tertiary care corporate hospital, not all of us have a complete control over what our anesthetist is going to give. We are as such taking consent, we are worried, there is a fetal distress, we are rushing the patient to the OT, we are counseling the patient, we are doing everything that is right. But the decision to give a spinal or a general anesthesia, ultimately you would agree with me, rests with our anesthetist. So, in hindsight, the entire outcome depends on how the various teams that work with us work in cohesion and work to the to the end of it. Like you yourself mentioned that you feel that possibly if a general anesthesia had been given, you could have saved that baby, Dr. Ila. You mentioned that. So there have been times when we've also had that same feeling, but we have been helpless because it's not like you can, insist. Like I had an abruptio some time back, and thankfully everything was done possibly. It was just too bad that we couldn't save the baby. But sometimes I feel that things could have been done faster. And everyone, each one of us, if we, just think about it, we do realize that there have been times when, things could have been, but they were not in your hands, basically. That's what I'm trying to reiterate. No matter how fast you are.
I just want to say.
Shashi, you want to say something? Shashi?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Please
Am I audible?
mute yourself so at least the voice becomes clearer.
Yeah. Am I audible?
Yes.
Yes.
Yes. I just want to share an experience. We have delivered many patients of VBAC in our hospital, but we should follow two precautions. One important thing is, as the Williams Obstetrics says in Parkland Hospital guideline, that we should restrict ourselves from inducing a case of previous cesarean, whether she had a previous delivery or not. And second thing, we should not induce or augment these cases. So if we follow these precautions, then chances of scar rupture will be less. If a patient comes in 3 to 4 centimeter in active labor and is progressing normally 1 centimeter per hour, it's better to deliver those patients only through VBAC.
I think, I
Good evening, ma'am.
agree with what Dr. Shashi has said, but let me be very frank with you. Spinal anesthesia or general anesthesia has nothing to do with saving the child. Let me be very frank with Dr. Ila. With the spinal anesthesia, you can do anything, and surgery can be very safe, and the anesthetist's hands are also free. So I feel anesthesia, general or spinal, does not make any difference as far as the child survival is concerned. Anybody wants to speak in the last minute? Anything?
Yeah.
What the message goes from here?
Good evening, ma'am. I'm Dr. Kusum Sahni.
Yes, Dr. Kusum.
Yeah, I just wanted to, the opinion of the house, because Dr. Jyoti said that as routine, after the delivery, if it is a vaginal delivery, she has a habit of exploring the scar, the lower segment, which we have also been doing while we were in Harding and all. But lately, this has gone out of practice. So I just want to know the opinion of the house, like whether it should be done or it should not be done, and your expert opinion on that.
We will take up, Dr. Kusum Sahni, this question. Anybody else wants to ask any questions, or we will sum up in the end?
Ma'am, I would like to know about the role of measurement of myometrial thickness at the scar site. What importance should we give? Should we actually depend upon the scar thickness and then take a call regarding VBAC or elective C-section?
Dr. Jyoti will be able to speak a little more about it, but I know any scar which is more than 3 millimeter is safe. But there is a technique of doing when you are measuring the scar. Dr. Jyoti, will you like to speak on that?
Yes, Dr. Jyoti. We don't have to rely totally on the scar thickness or the myometrial thickness of the ultrasound findings. Any scar thickness of more than 3.5 is quite reassuring, but at the same time, it has a positive predictive value as well as a negative predictive value. And much more important than scar thickness is the scar tenderness, both clinically as well as while doing an ultrasound. If the patient winces, that means she has probe tenderness. Definitely, she's either she's not the right person for VBAC. And another important thing while doing the ultrasound is absolutely empty bladder, whether an abdominal ultrasound or a transvaginal ultrasound. Transvaginal definitely gives a better opinion regarding the scar, but one has to learn how to do a transvaginal as compared to a transabdominal, because higher the frequency, better we can see. And because if we have any amount of urine in the bladder, it will stretch up the UV fold and may give a falsely thinner scar. So much depends upon the how much urine is there on the bladder. It should be totally empty while performing this thing, and it is not a very reliable thing. We do not rely on scar thickness at all for our VBAC patients. the other criteria as mentioned by Dr. Neha are much more important to decide in choosing a patient, the right selection of the patient for a VBAC, which is very important. I hope I have
let me just sum up as a person who sits on the other side. As a DMC expert and an MCI expert, I will tell you what are we looking at it. One thing is very clear: when the patient comes to you with previous cesarean section, you have to make up your mind and you must have documentation in place. There is a good 9 months at your disposal. If you want the records, the patients can get the records for you, and things of that kind can be done. So you can make up your mind what is going to be the integrity of this particular scar. Should you be giving her a vaginal delivery? Should you not be giving her vaginal delivery? But I think, I firmly believe with Dr. Chitra Setia that 3 weeks in advance, around 35 weeks, you must hand over the paper of the consent as well as the patient information things to her, and husband and she should go through it thoroughly without the language barrier, that they have gone through it and they are still willing for vaginal delivery. And down below, when they say they are willing for vaginal delivery, you should be able to say, I have been explained again that I may require a repeat cesarean section. My uterus can have a dehiscence. Do not write rupture. My uterus can have a dehiscence of scar, and the baby can die, or the baby can have a neurological sequelae. This has been very correctly, I have understood. These 4 points are very important. What I feel is, not only Shakuntala's case, one more other case also, the gynecologist was, unnecessarily harassed that she was induced. I think anybody who's an MD gynecologist, specialist gynecologist knows that she is not going to take a patient for VBAC in case if the labor she has not come spontaneously, because spontaneously if she comes into labor, chances of success is much, much more. Thirdly, whatever the signatures are there, at the time when she reports to you in labor, you have to see to it, where is the head, what is the Bishop score, what are you going to do, and you have to see to it that the continuous fetal electronic monitoring is there and good help is available. If the good help is not available, they can just can claim on things. So I think one thing is there on the record should be should be complete. As for the pediatricians are concerned, now I find in a labor notice should be written down whether the labor was induced, tick should be there, and your signature, whether labor was augmented, tick and your signature should be there, and whether the pediatrician in such cases is present or not. I think a couple of those things are very important in such cases. Let me be very frank with you, Dr. Sani. These are guidelines. They give you an overview. These are not the laws. You with your specialist qualifications, you can definitely frame your things the way you like it. If you feel that this thing has to be done, I as a policy matter always explore the law segment. If it's fully dilated at that particular time, you have to only put 2 fingers and then see where from one end to another one. I still feel if people who are confident, people who are not fidgety, people have a control on the fingers, they should definitely explore. That's the way I do it. And I think, a few years are remaining with me on obstetric practice, I will continue to do that. Secondly is that even if you found that there is no scar up top, this particular patient for the next 6 hours should be on a very close monitoring pulse and blood pressure. So the pulse anytime goes over 100 and the BP comes down anytime less than 100, it is something to be worried about. And you should definitely keep a watch on it. You don't have to have a very hi-fi things to know things. Obstetrics is an art, and I think, even without all those kind of things, we can definitely see our patients can have this thing. And I find, documentation is very, very, very important. Dr. Chitra is here again. I would like to have a little summary from her in case if she's around.
Yeah, I'm very much around.
Dr. Chitra, you sum up, and I think, what I want is that every gynecologist in this country, I can see Ritu Khanna here, she's in charge of it. Every gynecologist should have this consent and the patient awareness sleeve. If you can give it to us in a digital form, I can see to it across the country. I can send it across. And at 35 weeks, they should give it to their patients and things like this. These two things are very important.
I'll send it to you. And I think the first thing is the patient information leaflet to be handed over. In that, in the end, I have signatures of the patient, the witness, and the interpreter. So as I told you, we're going to shift it to one English and one Hindi anyway. So if they can't understand English, we give them a Hindi form. And if it's some other language, then we do not have facilities for that. Then we get an interpreter or let them get it read from somebody, and an interpreter signature should also be there. In this medical legal era, I think we will need to do all that. Secondly, this form is to be submitted along with the VBAC consent form when the patient comes in labor. And ideally, in the next, like you give it to her at 36 weeks, when you've decided whether you're planning for a TOLAC or not. And after that, when they come for the next visit, you should have a scanned copy of that leaflet form, because there is a date also mentioned, expected date of delivery and date of handing over the leaflet. So both those dates are there, and we should get a scan of that in our OPD record that this leaflet has been given to them. And this leaflet is to be submitted and along with the consent form of VBAC when they come for an admission. These are two things. Secondly, the moment the patient comes in labor, it's preferable that the patient is kept nil orally. You give her fluids IV, but keep the patient nil orally so that any urgent cesarean can be done. The relatives are told that you will be there. You're not running away, so that if we need the consent, and we tell them also that any time she may require a cesarean, so they have to be around. And record keeping in these cases is very, very important. Your notes. So many times you tell the resident, okay, write the notes, I'm going, I'm in a hurry. Write 2 lines and put a signature on their notes. That is very, very important. Notes have to be very clear. You should do a pelvic examination quite regularly, maybe more often than in a normal case, and these should be recorded. And any dissent on the part of the patient or the husband should be recorded, and this communication should be, I told you, communicate, document the communication. That is also very, very important. Whatever the patient is not agreeing to or the husband is not agreeing to, write it. There was one case where they kept, postponing the case. No, madam, abhi muhurat nahi aayi. No, madam, abhi husband nahi aaya. The people that was 80, it went on postponing. And finally, by the time the patient was taken for a cesarean, it was an hour past. And the baby had it was a very bad neonatal outcome. Later, they said that you did not tell us all this. Now, if all this had been documented, the doctor would not have been sued, would have been able to get away. Like Shakuntala had this very good thing that everything was documented. So the most important thing is documentation. Anything even other than consent is documentation of the consent. What is written is there in black and white. The law sees that. Nothing else. They're not going to believe your word for it. So that is.
I have one word, ma'am. There is only one problem that we have, and that is when we are doing a continuous monitoring. This is one gray zone that I find, and that is that we are not able to document. We have to verbally tell this. I was taken into.
You call them, and periodically, like whenever there's a dip or something, we take a scan of that and attach it.
There was no dip. The recording was continuous. The patient knows about it, and despite of that, I was alleged. That is what I was saying.
Whenever you're right,
Shakuntala, we are not discussing your case. Your presence and your experience, probably people, when they learn it, they know how to correct oneself.
Yeah. No, ma'am, I just wanted to, ma'am, my question is that when we are doing continuous, how do we document it, the continuous monitoring?
In your notes, that continuous documentation.
It's very easy. The area which is abnormal, you should scan that area only.
Yeah.
And keep it in a file. Cut that particular area, scan. Whatever is abnormal, आपको जो लगता है उसको scan करके रखना है. और scan करके रखना नहीं तो वो तो सब गायब हो जाएगा.
Exactly.
Now I want beside Dr. Shakuntala, I want 2 volunteers who will see to it that TOLAC is discussed every 2 months. till the time, the people, every gynecologist feels that they can do it. Because I think, just like nursery rhymes, the people have to just time and again, they have to be told. I only want the consent should be there. So who are the people who are going to volunteer with Shakuntala?
I'm there.
I'm there.
So Dr. Chitra, Dr. Shakuntala, and Dr. Ila.
Me too,
But
ma'am.
then you have to do it. Huh?
Dr. Leena is also there.
Yeah.
Me too, ma'am. Me too.
Anyway, we put up whatever, किसी को अच्छा लगे नहीं अच्छा लगे, हर 2 महीने में इसको हमने करना है. Till the time you're conscious about the consent part of it. Because I find, let's do it, even people like it and do not like it. So every 2 months we
Yes,
should
ma'am.
have one exercise like this. Today's exercise has been
Absolutely.
excellent, and we have to see to it that we modified in the future. So thank you very much about this. The forum is already right here. Shashi Kabra was here, who had taken, Shashi and Leena have taken a lead. As far as PPH, 1/3 deaths are related to PPH. And again, I can tell you, you need to skill all your gynecologists with all the sutures, with everything. But I think as a person who's sitting on the other side of the table wants that you should know to do a good cesarean section, and you should be able to do